Welcome to the real stream as opposed to the critical care stream. So of course we have the clinical care stream because most of us don't just do CICU and ICU. You know, we have a combination in our practice. So I'm going to go through some housekeeping. That's me, of course. I'm Sean Balmain. So you've signed in. Polling questions. So if you want to ask any of our speakers a question, scan the code. And then obviously scan the code for your evaluation form at the end of the day, and you'll get your certificate. So I'm going to start with our first speaker. So I'm delighted to present Dr. Zieroth, who's a professor at University of Manitoba and the director of the heart failure clinics there. She's been the president of Canadian Heart Failure Society. She's been president of the Federation of Medical Women of Canada. So I'm delighted she could come and join us to talk about in-hospital heart failure care, decongestion, and initiation of GDMT. Thank you, Shelley.
Awesome. All right. Well, thank you all for showing up. I think I saw Jay Udell's in the room. It's the room to be in then, right? And it's a pleasure to be here in Toronto and actually the first ever C4U conference. What a turnout. Congratulations to the organizers and the planning committee, and thank you for the opportunity to present today. You can find me on @Shelley Zieroth on pretty much every social media thing from X to Blue Sky and even Instagram. These are my disclosures. I am involved with consulting with several industry partners, both pharmaceuticals and devices, involved in clinical trial development and leadership, and I have non-industry affiliations as well. I'm currently the CCS HFpEF guideline co-chair. I'm going to put a plug in that those are going to be coming out in Q2 of 2025, and some global guidelines as well. These are our learning objectives today. We're going to look at decongestive strategies and GDMT for in-hospital initiation, and Dr. Van Spall will be talking about outpatient optimization of heart failure therapies as well. So I'm going to start off here, like this, all the way around the room. You can see it all. This is a survey. It's a global survey conducted by the European Society of Cardiology. There were cardiologists and non-cardiologists from over 65 different countries answered this. And I guess the big question is, how do you decongest your patients? And it turns out we all perhaps do it a little bit differently. I think you've probably all heard of the fact that most patients are even discharged from hospital without a successful decline in their weight. So this is really important. You can see here that there were differences on the bottom portion of this slide. So you won't see it at all because these screens are maybe a little tiny. So blue is cardiologists and orange is non-cardiologists. There's even differences in the way that people decongest their patients. So a cardiologist is more likely to add a thiazide diuretic, whereas non-cardiologists are more likely to increase the loop diuretics and add spironolactone. I think the majority of people answering the survey thought 0.5 to 2 kilograms a day of weight loss is the target. Do we get to it? Probably not. I think most of us even have a challenge getting daily weights in hospital as well. And God forbid the discharge summary on a patient discharged from hospital with heart failure has the discharge weight in it. Not useful whatsoever. Please change that with your EMRs. And then even what they consider success. It's a little difference between cardiologists and non-cardiologists. Cardiologists consider themselves to be successful when there's no congestion, preserves systolic blood pressure, and improves kidney function, whereas non-cardiologists even consider minimal congestion successful. They go out the door with some edema on board. That means they're more likely to bounce back, which was demonstrated in this study. This is a post hoc analysis of dose acute heart failure and caress heart failure, and kind of a neat scale of a combination of orthopnea and edema called orthodema score. And what they did see in particular, that those patients who were discharged without orthodema in the blue here we're less likely to have any follow-up peripheral edema. This is logical. But what they also noted is that those 52% of patients that were discharged free from orthoedema had lower 60-day rates of death and rehospitalization or unscheduled heart function clinic visits. So decongestion is important and has an association with reduced recurrent hospitalizations as well. So I want you to look closely at this figure. This is, I think, the nicest figure showing where all of these different diuretics work. You know, I haven't really looked at a nephron for a long time since med school, but the kidney really is important when you are a heart function cardiologist. I'm married to a nephrologist, but we don't spend a lot of time talking about the loop of Henle around the dinner table, for instance. I think it's really interesting that a few of our GDMT therapies are being perceived as well as a potential diuretic option and find their way, particularly SGLT2 inhibitors are on the next figure for consideration of a diuretic mechanism. So we have our acetazolamide. We're going to talk about the ADVOR trial. SGLT2 inhibitors, they're working more proximally. Then we have the loop diuretics in the thick loop of Henle here. Vaptans work in the distal convoluted tubule. We're not going to talk a lot about it, but tolvaptan is a therapy used in hypervolemic hyponatremia in some institutions. Not everybody has this on their formulary, and we'll go over the mechanism of action. MRAs, late distal convoluted tubule. And so I will go to this slide, which more accurately describes the exact mechanisms of each of these. I mean, I'm not sure I care so much about exactly how they work. I'm not a big receptor person here. I don't like talking sodium-hydrogen exchange. But I want you to think about diuretic resistance and using therapies that work in different areas of the kidney may be an important strategy to improving decongestion in our patients. Now, I'm also going to bring up something called fact-checking figures that you show. This has been published in JACC-HF, and I'm going to go back to them and show them something so that tolvaptan, this figure here is making it look like tolvaptan, and the V2 receptor is in the loop of Henle. It's not. It's the distal convoluted tubule. I had to fact-check that 3 times this morning before coming. So make sure you always look at your figures before you present them to a big conference. ADVOR trial. This was a trial about decongestion and diuretic therapy published in the New England Journal of Medicine. Who knew that decongestion could be so cool to make it to New England Journal of Medicine? This is actually one of the largest diuretic trials in acute decompensated heart failure. And they randomized patients to, who were volume overloaded to loop diuretic with the addition of 500 milligrams of IV acetazolamide. And those patients randomized to acetazolamide had a higher incidence of successful decongestion. So it met its primary endpoint. It was consistent across subgroups. And patients who were treated with acetazolamide had more natriuresis, shorter hospital stays, and were more likely to be discharged without residual volume overload, so they would have had a low orthoedema scale. There was no reduction in events, but these diuretics trials really aren't adequately powered to show clinical event reduction, but we always seem to see signals and trends in that way. So this highlighted the importance of augmenting and using a dual mechanism strategy for decongestion in patients admitted to hospital with acute heart failure. So this is a fairly big readout. Next, this is the PUSH acute heart failure trial, the pragmatic urinary sodium algorithm. And so this used a strategy of monitoring urinary sodium to escalate diuretic requirements. If you go into the methodology of this paper, it may give you a really practical hands-on tool to use during a heart failure admission. And so patients, 310 of them were randomized to urinary sodium guided versus standard of care, in which patients received twice IV daily diuretic, pretty standard. Spot urinary sodium was determined at 2, 6, 12, 18, 24, and 36 hours. That's pretty frequent. Again, in a healthcare system in which it's hard to get a weight, I'm not sure how easy it is to get a urinary sodium unless you get the patient to do it for you. And I think a lot of our nurses are stretched. We intensified therapy in this trial with a spot urinary sodium less than 70 or less than 150 mils per hour of diuresis. There were two primary endpoints. The first one was hit at an increased 24 hours natriuresis in those patients who had this urinary sodium escalation protocol applied. But there was really no significant difference in all-cause mortality or heart failure hospitalization at 180 days. The MPulse trial has also shown successful decongestion, particularly early on. In the blue line here, you see the adjusted mean change in body weight is fairly rapid due to the osmotic diuresis that we see with patients, and even adjusting it per baseline loop dose diuretic. Remember, the MPulse was an in-hospital initiation of empagliflozin in hemodynamically stable patients. They were not on inotropes at the time. There was hemoconcentration early on with the empagliflozin randomized patients, and their clinical congestion scores also were numerically improved. So one of the challenges in some of these patients in particular is the concept of diuretic resistance. When you have them admitted, you have them on high-dose diuretic, and they are not necessarily improving or diuresing to the level that you need them to. And then we have to think about augmenting and adding in co-diuretics as needed. So prevention and treatment of diuretic resistance, how do we do it? What combination do we use? Well, I think it may depend on the patient, but I do think that SGLT2 inhibitors are probably an important element for initiation. One, because of that early osmotic diuresis that we see in these patients. Two, because it is an element of GDMT regardless of ejection fraction. And so this was an interesting study called DAPA-RESIST, in which patients on IV diuretic who had diuretic resistance were either randomized to dapagliflozin versus metolazone, and so each resulted in similar weight loss, but with less metabolic abnormalities with SGLT2 inhibitors. Now, how do you put all of this together? I'm actually just going to show you here really briefly that there was some outpatient assessments. I know there are clinics that do in clinic visits IV diuretic dosing. There have been comparisons as well of IV with oral metolazone or IV furosemide with IV acetazolamide. And you can see that the IV furosemide and metolazone combination in an outpatient urgent heart function visit had a significant higher level of natriuresis in comparison to the other combinations. So something to think about there. But this is a slide from Wilfred Mullins, who I consider to be the prince of diuresis. He really is the decongestion king. And this is his algorithm for optimizing decongestion, and it still holds true. So consider applying the ADVOR strategy on the early first days of acute heart failure, adding in an SGLT2 inhibitor, particularly when there's no escalation in IV diuretics, and in chronic heart failure, optimizing GDMT. I'm going to talk to you very quickly about the STRONG trial coming up now, but one more thing to put out there, and I don't know if you have it here at UHN, is this pump. It's called the Furosix pump, and it's a sub-Q pump that patients can put on themselves to administer to themselves a 30 milligram sub-Q bolus for 60 minutes, followed by an infusion, which can be repeated daily to avoid the need for travel, long distance, particularly in provinces, well, all of our provinces, frankly. And I actually asked the company, you can mail out these pumps. They are cold resistant as well, which I was concerned about, mailing out a pump to a patient in the middle of winter. But this is something that should be hitting the Canadian market in the near future. You can see that it achieved diuresis equivalent to IV furosemide in clinical trial testing. So it's sub-Q pump, self-administered by the patient. Again, this could be a really important strategy for avoiding an acute heart failure hospitalization. So we focused on diuretic-centric paradigms, which thus far have had no significant impact on mortality. It's an important strategy probably for reducing recurrence of hospitalization, but we also need to implement in-hospital GDMT. We know in-hospital initiation of therapies increases patient adherence, and in healthcare systems like Canada, where not all patients go to a heart function clinic, this may be the only touch point as well in which patients have the opportunity to be put on disease-modifying therapy because of a lack of heart function clinics overall in our country. In hospital initiation, let's start with sacubitril/valsartan. This is a pre-specified pooled analysis of both Pioneer HF and Paraglide HF. One was a REF study in hospital initiation. One was a mildly reduced and PEF study for in-hospital initiation. And in fact, and this is the algorithm, slight differences in natriuretic peptide levels for inclusion criteria. But what they did find on this pooled analysis was a significant reduction in NT-proBNP. This is often used as a surrogate endpoint for in-hospital initiation studies because the numbers are a little bit lower in these trials, so this tends to be the surrogate primary endpoint. But in the pooled analysis, what they did see was there was a significant reduction in cardiovascular death or heart failure hospitalization, regardless of ejection fraction, in patients randomized to in-hospital sacubitril/valsartan. It's important to note that these patients are considered hemodynamically stable. They are not on IV inotropes. They're having no escalation of IV diuretics and no IV vasodilators, okay? MPulse trial, in-hospital initiation of empagliflozin in a hemodynamically stable patient population, regardless of diabetes status, regardless of EF, de novo or known chronic heart failure. Those patients who were randomized to empagliflozin were 36% more likely to experience a benefit in comparison to those who received placebo. This was a win ratio analysis, mostly driven by an improvement in KCCQ scores, but the safety profile is consistent with outpatient ambulatory use for both sacubitril/valsartan and for MPulse, safe to use in hospital. This is a recent publication from the Canadian context looking at the eligibility for disease-modifying therapy in hospitalized HFrEF patients. You can see the number of patients eligible based on inclusion criteria for sacubitril/valsartan is extremely high in our in-hospitals admissions for heart failure in Canada for HFrEF. Let's go to SGLT2 inhibitor. There's lots of opportunity here to prescribe GDMT within the Canadian context. In fact, this figure shows the eligibility for in-hospital initiation of quadruple therapy in HFrEF. I hope we're all performing audits to see if our performance is getting anywhere near this. And of course, let's not forget about HFpEF. This was, of course, before even the DELIVER trial was published, this analysis that was performed. But you can see the eligibility in even PEF patients is substantial. So the STRONG HF trial was an important implementation study which looked at the use of high-intensive care versus usual care prescription of GDMT. It did not include patients or include SGLT2 inhibitors just based on the timing of this clinical trial. And it enrolled patients regardless of ejection fraction. But the goal in the high intensity care group on the top was to introduce half optimal doses of heart failure therapy in hospital. And that's something I think that we should all strive to attain. It had rapid follow-up in the intensive care group within 1 week, with safety parameters being NT-proBNP and vital signs. And you can see that by week 2, patients were already at full target dose of GDMT. And this trial was actually stopped early by the Data and Safety Monitoring Board because there was a significant reduction that they were seeing in 180-day heart failure readmission or all-cause mortality in favor of those getting this rapid, high-intensity care. So speed definitely matters, and in-hospital initiation is an important part of starting that GDMT. We know that there was improvements in NT-proBNP using this rapid strategy in the STRONG protocol, and again, improvements as well in clinical outcomes. What I thought was also interesting, though, was in-hospital initiation of GDMT, rapid follow-up. It actually also led to effective, sustainable decongestion in these heart failure patients. The congestion scores, the lung congestion, the weight, the NT-proBNP, the dyspnea, all was significantly reduced with appropriate prescription of GDMT rapidly. And those who had successful decongestion at 90 days had an even more marked improvement in clinical event reduction. So a side-by-side strategy of decongestion and GDMT is very important for both our patients and the healthcare system as well. Clinical trial data supports the feasibility and the safety of in-hospital initiation. And decongestion per se, there are many different strategies that we can use. Think about in a patient with diuretic resistance as well, about adding in additional therapies. And perhaps urine sodium monitoring would be important for us to implement at some level, perhaps not as aggressive as some of these clinical trials, but it is a useful tool to look for an opportunity to augment therapy. I just want to take the last minute here to put out a plug for our heart failure update conference. I think we're at year 12 or 11 this year. 12, there it is, 12th annual. And it's going to be here in Toronto as well. So we're going to Hotel X, which is quite an interesting venue. And we have many international speakers and Canadian speakers coming. So if you want to scan the QR code, early bird registration is still on till the end of February, or you can go to hfupdate.ca, which will give you the opportunity as well to register for this conference and learn more about the management of patients with heart failure. Thank you so much.
Thank you, Shelley. That was fantastic. Please remember to use the Slido to put your questions in. I'll be collecting all of your questions, and I'll put them to the panel at the end in our Q&A session. Our next speaker I'd like to introduce is Dr. Harriette Van Spall. I'm delighted she could join us today. She's an associate professor in cardiology at McMaster and a cardiologist in Hamilton, a senior scientist at Population Health Research Institute, and a scientist at the Research Institute of St. Joe's in Hamilton. She is an associate member of the Department of Health Research, Methods, Evidence and Impact, and the Director of Implementation Science, Balmain Institute for Clinical Research in Hamilton. She's going to speak to us about something that we all think we know about, which is ambulatory heart failure care, but I don't think we all do it that well. So she's going to educate us today. Thanks, Harriette.
Okay. Thank you so much for inviting me. Jay, you should give this talk. I'll try not to be nervous that you're in the room, but it is an absolute joy to be here this morning. We have somebody who is who used to be a nurse practitioner in our heart function clinic. She's since moved institutions, but it's so nice to be reunited with people and to see new faces. Thank you all for showing up this morning. I will focus on ambulatory heart failure and begin with this slide, which depicts our analysis of the global burden of disease data set. This cut is from 2021, and it demonstrates the prevalence of heart failure across the world. There are 56 million people who live with heart failure. Half of them are female. 750,000 of them live in Canada. Now, Canada has a small population relative to the global population, but if you adjust for age and population size, Canada is the leading country for heart failure prevalence in the world. Canada, United States, and China. And heart failure, as we know, is a disease that's highly prevalent in older adults. But our health systems aren't equipped to deal with the problems that older adults face. And so we deliver care in silos that are organ-based, rarely integrating the care experience and medical therapies required to treat heart failure effectively. We classify heart failure in many different ways. One of them is ejection fraction. And we have these classes of reduced ejection fraction. This is heart failure with an EF less than 40%. Mildly reduced ejection fraction, which reflects people who live with heart failure, and an LV ejection fraction of 41 to 49%. And then heart failure with preserved ejection fraction, which reflect those people who have an LVEF of 50% or greater. And in our minds, we often treat heart failure with reduced ejection fraction with greater urgency. But it's important that we recognize that patients face the similar risk of death and readmission regardless of ejection fraction. So the left survival curve shows you our analysis of data in Canada with people across ejection fraction categories. Half of all of our patients have heart failure with preserved ejection fraction, for which we still have little effective therapy to reduce mortality in. They have the same risk of death and of all-cause hospitalization as people with heart failure with reduced ejection fraction. You see these curves near completely overlap. The data on the right depict analyses from global data sets. And here you can see that heart failure with reduced ejection fraction, shown in red, has a similar one-year all-cause mortality as heart failure with preserved ejection fraction, shown in orange. But the absolute rates vary across data sets, and this often reflects the demographics of people and the quality of care. Note, if you will, the high mortality. One-year mortality following hospitalization for heart failure is 25%. 1 in 4 patients die. And they often do not know their prognosis when they leave hospital. And we often do not treat them with the urgency that we ought to. So the death rates are higher than many solid cancers. And yet, patients face delays in care, delays in up-titration of therapies, and avoidable readmissions. This slide is adapted from the ACC-AHA guideline slide, but it is different, and that's why I don't have a reference here, because I have incorporated recent clinical trial data that have yet to be incorporated in guidelines. This shows you the continuum of disease stage, ranging from stage A, which reflect people who have risk factors for heart failure, but don't yet have structural heart disease, elevated LV filling pressures, or clinical heart failure. Stage B is the next stage, which includes people who have structural heart disease, elevated LV filling pressures, elevated biomarkers, but don't yet have clinical heart failure. Stage C are those patients who have symptoms and signs of heart failure. And then stage D are those patients who have advanced heart failure with limiting symptoms at baseline, at rest, even though they have been optimized on therapies. These patients cycle in and out of the hospital with heart failure and have perturbations in hemodynamics as well as electrolytes and organ function because they have reached the terminal phase of their illness. Across stages, there is room for lifestyle interventions to improve quality of life and to improve outcomes. Some of the risk factors that we tend not to talk about, but that we could, include nutrition, exercise, 7 to 9 hours of sleep a night, tobacco-free lifestyles, and alcohol-limited lifestyles. I won't go into the data supporting some of these, but these should be part of the coaching that we offer patients. Some patients require medical treatment for these risk factors, and their interventions for tobacco cessation, their interventions now for alcohol cessation for those who misuse alcohol. We have an increasing understanding into the role of obesity and in particular adiposity in inflammation and in heart dysfunction. There are now medical therapies that we can offer patients to reduce risk from these sources. And then of course, hypertension, diabetes, and dyslipidemia have medical therapies that are underutilized because we tend to underscreen patients and then undertreat them, and patients do not have complete adherence to the recommendations we make. CKD is an important risk factor as well that requires early intervention to reduce the incidence of heart failure. And across stages, we need to be concerned of heart failure that has not yet risen, and then to detect it in those patients at risk. So there's a role for symptom, biomarker-related, and echo-related screening. The therapies I will now discuss that apply to early stage heart failure also apply to later stages of the disease. So in stage A, we think about screening for risk factors and then treating them. And so I'll just hit upon some of the high points in therapeutic approaches for the risk factors for heart failure. So we now know that both SGLT2 inhibitors and GLP-1RAs have a role in treatment of CKD, as do MRAs in those patients who have diabetes as an underlying cause of the CKD. But we know SGLT2 inhibitors and GLP-1RAs that we have traditionally thought of as diabetes drugs also apply to kidney patients who may not have diabetes as an underlying cause. ACE inhibitors and ARBs are evidence-informed interventions for patients who have CKD. And those patients who have cardiovascular risk factors and adiposity or obesity as a driving risk factor, there is a role for GLP-1RAs. We know that from the SELECT trial. Patients with stage B heart failure includes those who are post-MI, and there's evidence to support the role of statins in these patients. Regardless of etiology, if somebody has an LVEF less than 40%, beta blockers and ACE inhibitors or ARBs should be initiated to decrease the risk of incident heart failure. People who have cardiovascular disease and BMIs of 27 or greater could benefit from the initiation of GLP-1RAs to reduce the incidence of heart failure. And then there's a role of ICDs in people who are post-MI. That's not so much to reduce the incidence of heart failure, but to reduce the risk of death if your LVEF is persistently impaired, less than 30%. Then we move to stage C heart failure. When patients are congested, there's a role for diuretics, as Dr. Zieroth has gone over. The mainstay of these therapies include loop diuretics. In patients who have HFrEF, there's very clear and long-standing evidence for the use of beta blockers, ACE inhibitors, ARBs, and more recently ARNIs, for which we have multiple lines of evidence to support, more than one clinical trial, and MRAs. We know that both steroidal and more recently non-steroidal MRAs can improve the primary outcomes of death or heart failure events in people with heart failure. The evidence for MRAs is greatest in patients with heart failure with reduced ejection fraction. SGLT2 inhibitors are guideline recommended across jurisdictions because we have good clinical trial evidence across the EF continuum that they reduce the primary composite endpoint of cardiovascular death or heart failure events. And then more recently, we have evidence to support the use of GLP-1RAs in patients who have heart failure with preserved ejection fraction and an elevated BMI of 30 or greater. And then we come to stage D, and these are patients who we offer therapies to as long as they can tolerate them. Of course, we often deal with having to down titrate therapies, and I'll talk to you about some tips and tricks to maintain therapies across stage D heart failure. We then get into having to talk to patients about their goals of care and advance them for LVADs or cardiac transplantation. There's little evidence to support the use of ambulatory inotropes, but this is something we do to some patients to help decongest them in some cases, and then, of course, palliative care. So this is a slide that delves greater into the stage D and stage C heart failure across the EF continuum, and you see that SGLT2 inhibitors are supported by the DAPA-HF and EMPEROR-reduced trial at the lower range of EF, by the EMPEROR-preserved and delivered trials at the higher range of EF. MRAs I will get into. So we have strong evidence to support their use in HFrEF and more recent evidence to support their use in HFpEF. ACE inhibitors, ARBs, and ARNIs are recommended in HFrEF, and then with modest evidence in heart failure with mildly reduced EF and preserved EF. And then beta blockers, I should say, we have strong evidence to support them in HFrEF, but really no clinical trial data evidence to initiate them or use them to manage heart failure in HFpEF, even when we looked at pooled analyses. And then I added GLP-1RAs based on the recent STEP HFpEF and SUMMIT trials that I will get into. I'm not going to go into the clinical trials for some of our historic lines of GDMT, but this graph of ours shows the change in risk of all-cause death when we initiate the pillars of heart failure therapy in HFrEF. Patients benefit from up to a 60% reduction in all-cause death when they are on the 4 pillars of HFrEF therapy. We'll talk about some of our recent trials, beginning with the SGLT2 inhibitors in HFpEF. And a lot of the recent trial evidence is primarily in HFpEF, which we had historically few therapies for. But there's great hope and excitement that our new classes of therapies can improve outcomes, particularly heart failure outcomes and heart failure events in people with heart failure at the higher range of the EF continuum. So the DELIVER trial tested the efficacy of SGLT2 inhibitors, and specifically dapagliflozin at 10 milligrams daily in patients with heart failure with an EF greater than 40%, and showed about a 20% reduction in the incidence of cardiovascular death and heart failure events. This was primarily driven by a reduction in heart failure events. And the EMPEROR-preserved trial tested the efficacy of empagliflozin 10 milligrams daily in patients with heart failure and an EF greater than 40%. Again, it showed about a 20% reduction in the cumulative incidence of cardiovascular death and heart failure events, driven primarily by a reduction in heart failure events. So neither of these trials reduced cardiovascular death by themselves or all-cause death. The non-steroidal MRA finerenone was recently tested in patients with HFpEF and HF mildly reduced EF. So the inclusion criteria were patients with heart failure and an LVEF of 40% or greater. And in this trial, the non-steroidal MRA finerenone had about a 20% reduction, almost a 20% reduction in the primary endpoint of cardiovascular death or heart failure events, again driven primarily by a reduction in heart failure events. Data were quite compelling when you pooled these patients with those who have cardio-kidney metabolic disease. So we have Fidelio and Figaro DKD trials that tested the efficacy of finerenone in patients with diabetes and kidney disease. When you pool all of these patients, a reduction in all-cause death was noted. There was also a reduction in the incidence of atrial fibrillation. I don't have those data here, but you know, there's broad indications for the use of MRAs, and I just want to highlight that just like SGLT2 inhibitors, we need to think about initiating therapies in patients before they get heart failure. And kidney disease is certainly something common we see in our general cardiology service in patients who don't yet have heart failure. So we need to think about initiating therapies to prevent heart failure. These are data from the STEP-HFpEF trial. It was a small trial of about 530 patients. It tested the efficacy of semaglutide with a target dose of 2.4 milligrams sub-Q weekly in patients who had heart failure with an EF of at least 45% and who had obesity as measured by a BMI of at least 30 kilograms per meter square. This slide shows you the effect of semaglutide on the dual primary endpoints of a change in KCCQ score, and this is a measure of health status, as well as a change in body weight. And there was about a 10% improvement in weight loss in patients who were on semaglutide as compared to placebo, and an improvement in health status of about 8 points in patients who received semaglutide versus placebo. There have been some criticisms. You know, was the trial truly blinded? People lost weight, and they might have been able to tell which group they were allocated to. But I think the important point is that they felt better. And what I don't show here are some of these secondary endpoints that show a reduction in cardiac-specific biomarkers and other endpoints that are relevant to clinical care. That trial was followed by the Summit trial that tested the efficacy of the GIP-GLP-1 coagonist in HFpEF using a cutoff of 50% or greater. Patients had to have obesity, so a BMI of at least 30 kilograms per meter square. And this shows you the first primary endpoint, the incidence of cardiovascular death or heart failure events in patients who were on tirzepatide versus placebo. There was a risk reduction of almost 40% in this small trial of about 730 people during the follow-up period of about 52 weeks. There was also an improvement in health status, about 6 points, and an improvement in 6-minute walk distance of about 20 meters. So quite substantial improvement in a small trial. Now, despite all of the evidence we have across the last 30 years or so, in therapies that have been tested in multiple trials, we have underutilization across countries, across regions within countries, and these data of ours show the uptake of GDMT classes in patients on the right across the EF continuum. And on the left, we have data from US registries. And what you will see is across countries, the use of RAS inhibitors is between 70 to 80%. The use of beta blockers is around 80%. The use of MRAs is around 30%. And the use of ARNIs specifically lower in Canada than in the United States. And that tells us that it's not just inertia. You know, the uptake of MRAs is about 30% even in Europe, right? There's side effects that patients experience, and I'll get into those. These are our analyses of 65,000 people in the US, and it shows on the left people who are young. The uptake of GDMT at optimal doses, which is more than 50% of target dose, is low. It's around 10%. And it's lower in females than males. The females here are shown in red, males in blue, and you can see that across the duration of disease, women receive target dose GDMT at less frequency than men. The right bar graph shows you older adults, whereas the left bar graphs show you younger adults. So in older adults, the uptake is even lower than in younger adults. And again, the same pattern of less uptake in females, more in males. These are data from Europe, and it shows you the reasons for non-use of GDMT. About 1 in 4 patients are not on GDMT or are on suboptimal doses because of intolerable side effects. And the first column shows you some of the side effects, and all of us can relate to this when we take care of patients, right? RAS inhibitors, we often are limited by hypotension, orthostasis or dizziness, worsening kidney function or hyperkalemia. Beta blockers, again, you see hypotension and orthostasis are common reasons for underutilization, as is bradycardia. MRAs, all of us know that we tend to hold them when people are hyperkalemic or when we fear hyperkalemia. And then SGLT2 inhibitors can be limited by urogenital infections, fungal infections, but they tend to be really well tolerated. Wouldn't you agree? And so we see a very interesting pattern when you look across registries, and I don't have the data, but the uptake of SGLT2 inhibitors has been much greater than ARNIs across countries, even though the evidence to support them are more recent. Why? It's a once-daily drug, doesn't require titration, doesn't require monitoring, and it's generally well tolerated. So those are other factors that we consider when we implement therapies. So some tips when the blood pressure is low. Assess signs and symptoms of hypoperfusion. Address reversible causes. Over-diuresis is a common cause of hypotension, so consider scaling back on the diuretic when appropriate. Deprescribe unnecessary therapies that lower blood pressure. Stagger your RAS inhibitor and beta blocker dose, so you could use a bisoprolol, for example, at noon, the ARNI in the morning and night. And as a last resource in people who are advancing and really hypotensive with no reversible cause, you may consider switching the ARNI to, say, a nighttime ACE inhibitor or ARB, having a beta blocker in the morning so that the blood pressure peak effect is staggered. And then in patients who need second-line therapies that don't reduce blood pressure, like digoxin, you may consider adding those. Discontinue and decrease doses of these life-saving therapies as a very last resort, and talk about goals of care and referral for advanced treatments in these patients. The reduction in GFR is a common reason for underusing medications, such as RAS inhibitors and MRAs. So initiating these life-saving therapies reduce GFR. That's normal. Not a reason to withdraw therapy or do anything dramatic like reduce the dose unless the reduction in GFR is substantial. So a doubling in creatinine would be a cause for concern, for example. But again, look at other things like volume before scaling back on doses. So the graph on the left shows you in green that a reduction in GFR is normal as people age. And the line on the left that's red shows you the precipitous decline in GFR in patients who have diabetes. So the GFR reduces rapidly in these patients as the disease progresses. An acute heart failure event causes a reduction in GFR that is normal. And of course, we attribute it to therapies that we initiate, but they're not necessarily related to the therapies. They're a function of the heart failure event. But we need to keep in mind that RAS inhibitors, MRAs, and SGLT2 inhibitors can decrease the GFR. Over the long term, however, they tend to stabilize GFR, so giving us reason to persist with therapies. When potassium is high, consider reversible causes, AKI, metabolic alkalosis, and then rhabdo and hypocalcemia can also cause hyperkalemia, so address those. And then think about using potassium binders so that patients can continue to receive the benefit of MRA therapy. Decrease your RAS inhibitor MRA as a last resource only in patients who have significant hyperkalemia. And we consider 5.5 to 6 as a basic threshold, not any lower than that, to withhold those therapies once patients are already on potassium binders. I have a slide on GLP-1RA tolerability. GI side effects are often a limiting factor. For these patients, starting slow, so starting at the lowest dose possible, having a slow taper, so instead of increasing the dose every 4 weeks, you could push it out to 8 weeks or longer. Having the patients eat small meals that are spread apart in time, having them note their triggers for nausea, which is a common side effect, and then decreasing the dose if those symptoms persist rather than stopping the GLP-1RA. I'm just going to end with this slide. In addition to interventions at the patient level, we need to think about system-level interventions that foster implementation of these therapies in a systematic way. Interventions that don't work, one of which I led, was a trial that tested the efficacy or effectiveness, I should say, of nurse-led interventions without an algorithm. So just having nurse-led care without an algorithm guiding the GDMT uptake is not effective at improving the GDMT uptake or at improving clinical outcomes. And that was tested in the PACT-HF trial. There were 2 other trials in the US that tested similar interventions. The Get With the Guidelines heart failure trial showed that quality metrics, so auditing and giving feedback to clinicians about the underutilization of GDMT, did not move the needle at all. There was not one quality metric or drug that increased implementation because of the audit and feedback. CONNECT-HF showed that post-discharge heart function clinics in and of themselves did not improve guideline-directed medical therapy uptake. What did improve uptake? At the patient level, having EHR alerts pushed to clinicians improves the uptake of some classes of DMT, specifically beta blockers. The EPIC-HF trial showed that. The STRONG-HF trial that Dr. Zieroth presented tested the effect of an algorithm-driven uptitration protocol quickly delivered after discharge, where patients were seen every 2 weeks. That did improve the uptake of classes of GDMT. And then at the policy level, supporting patients with co-pays, reducing their personal expenditure when they fill prescriptions, increase the uptake of medical therapies. And I'm just going to plug a trial that we have finished about 500 patients recruitment for, the Victory-HF trial. This is a virtual trial that tests the GDMT algorithm-driven approach in patients with a low-touch virtual care model and doesn't involve face-to-face visits or bricks and mortar. This is an international trial, and we're starting the Victory-HFpEF trial, which will test a virtual care option in patients with HFpEF, thinking about all of the cardiometabolic risk factors and delivering care in an algorithmic protocol based on phenotype. Thank you very much for having me.
So yeah, I told you were going to learn something. So Diego, you've got 2 fantastic talks to follow. I feel for you, man. I feel for you. But it's going to be okay. So, so Diego Delgado is a professor of medicine with us at UHN, a division, he's also a heart failure transplant doctor. He has been the go-to person, at least downtown Toronto, for years for amyloid heart disease. So I'm very pleased he's here to share his insights in where it's going. You going to go with the TED Talk approach or the hot mic approach? Hot mic.
I will walk around. Thank you, Jen. Yeah, so 2 great presentations and 2 great speakers. So it's a challenge, but we will try to do our best. Thank you for being here. So we're going to talk about amyloidosis. Thank you. These are my disclosures. And these are the learning objectives. I'm going to talk about the physiopathology, clinical red flags, how to identify these patients, how we monitor, and of course, how we treat these patients. So amyloidosis seems very complicated, but it's not, really. The concept is not one single disease. It's a group of disorders, which they have in common something, which is this protein amyloid. It's a very sticky protein that affects multiple organs, creating changes in the architecture, in the geometry of the organs, but also functionally, this protein can be toxic. And usually this disease affects multiple organs. And these are the 2 main type of amyloidosis. There are multiple, but these are the 2 that are most commonly seen that produce cardiac infiltration. One is the light chain or AL amyloidosis, and I will briefly talk about this, but I will put more emphasis on the transthyretin or TTR amyloidosis. So the light chain or AL amyloidosis starts with an abnormal clonal expansion of plasma cells that produce this abnormal antibody that then deposits in different organs. Usually it's associated with blood dyscrasia, and in more than 50% of the cases is associated with multiple myeloma. These are patients that usually younger patients in their 40s or 50s, and in general, these patients present with renal and cardiac compromise and can affect more than 50% of these patients with this disease. And then we have the transthyretin amyloidosis, or TTR amyloidosis, and that stands for transport of thyroxine and retinol. This is a protein that under normal conditions in all of us participate in the transport of thyroxine and vitamin A. Most of the production of the TTR is in the liver, and this protein has progress from this nice tetramer shape, that's a normal shape, and start misfolding in monomers that then subsequently transform in the amyloid fiber that is deposited in the organ. So the idea is, of course, trying to preserve this structure as much as we can, and for whatever reasons, in some patients, especially elderly patients, this structure changes, and that's what transforms into the amyloid fiber. So if we talk about the TTR amyloid, there are 2 subtypes. One is the hereditary or mutant TTR amyloid, and then the other one is wild type, previously known as senile amyloidosis. Hereditary is considered a rare disease still. It's a gene, it's an abnormality in the TTR gene. And these patients could have a cardiac phenotype or a neurologic phenotype. And I will discuss this in detail. And then we have the wild type amyloidosis, usually seen in elderly patients. There is no gene associated here. So the expression of these 2 types, so the phenotypic expression, depends on multiple factors, age being one of the main. But then there are many other factors that we don't know. We know that families with the same gene mutation, if they live in Portugal, they may have neurologic symptoms in their 30s or 40s. but some members of the same family, they are in Canada, and they may have cardiac phenotype in their 60s or 70s. So there is some discussion that could be some environmental factors, endemic factors that can trigger these phenotypes especially in the hATTR or hereditary TTR amyloidosis. This is just to show you the different type of genes. There are more than 120, 140 genes associated with these mutations or TTR mutations. I will mention probably this one, the V122, now known as V144. This is one of the mutations. And the other one is the B30 or V60M. You can see here the prevalence. This is exclusively seen in the African Caribbean population, around 4%, probably more than that. And then the V30 is mostly in Portugal. There are other mutations. What is interesting is that some of these mutations have pure cardiac manifestations, others are more neurologic. And then you have some of these genetics that can have what we call the mixed phenotype, so patients with cardiac and neurologic symptoms, which are in general the more challenging patients to identify and to treat. When we talk about the clinical manifestations, I would say that heart failure is probably the most common signs or symptoms of these patients, usually left ventricular dysfunction with diastolic dysfunction is the main manifestation of these patients. But then as the disease evolves, these patients will have systolic dysfunction. Atrial fibrillation in more than 20% of these patients is very common, and other conduction abnormalities or any type of arrhythmias. And then aortic stenosis, particularly the low flow, low gradient aortic stenosis, very common to see in patients with TTR amyloid. And then you can see here there is many extracardial manifestations of TTR amyloid and AL as well. Just to mention a few, autonomic dysfunction is very common to see, especially in more advanced cases with orthostatic hypotension or gastroparesis. Very common to see carpal tunnel syndrome, spinal stenosis in the TTR amyloidosis, and the gastrointestinal symptoms are very commonly seen. These are patients who usually are undiagnosed or misdiagnosed for many, many years, complaining of gastrointestinal symptoms until finally they reach the diagnosis. As you can see, the AL, mostly these patients have renal compromise with nephrotic syndrome, and of course they can have autonomic dysfunction and gastrointestinal symptoms. I want to mention the polyneuropathy, which is very commonly observed in patients with hereditary TTR amyloid, less frequent in the wild-type patients. But this is a disease that can progress very fast. So we have patients who are 6 months from the onset of symptoms, they can have significant limitations. Is usually distal and symmetrical polyneuropathy. These patients complain of pain, burning sensation. It's very distressful and creates a lot of anxiety. And it's very difficult sometimes to identify with any type of distal polyneuropathies. I would say that probably this one is faster in the evolution and usually do not respond to conventional therapies if you compare it to other polyneuropathies, for example, diabetes polyneuropathy. There are ways to diagnose this disease, and there is no one single test that we do in these patients. There is a combination of things that we use. We use biomarkers, particularly BMP and troponins. We know that these markers usually are chronically elevated, particularly in the AL patients, and this is related to the toxicity of the fiber that is more so than the TTR fiber. So these are patients who go to the emergency complaining of shortness of breath, and they have very elevated troponins and BMP, and they think, this is an acute event, or coronary event. This is usually what happens. It's more related to myocardial injury, related to the amyloid. ECG is another tool that we all use, but unfortunately the changes that we see here are usually more in late part of the disease, where we see the microvoltages, pseudo-infarct, arrhythmias, conduction abnormalities. So this is unfortunately a little bit too late in the course of the disease. And then one of the critical points is to rule out AL amyloidosis when we try to reach the diagnosis of TTR. So for that, we do serum and urine electrophoresis with immunofixation to increase the sensitivity for the diagnosis. And then we order the free light change. You probably hear about the kappa lambda ratio. Normally it's less than 1.65. Anything above that could be abnormal. That's one of the tests that we do and help us to rule out AL amyloidosis. Keeping in mind that the serum line change could be abnormally elevated in patients with renal dysfunction or patients who are more than 70 or 80 years old. So you need to be aware of that and determine if the patient has a truly blood dyscrasia or has eventually MGAS as a possibility. Well, definitely echocardiogram is one of the tools that we use. I think in the last few years, as we get more comfortable diagnosing TTR amyloid or any type of amyloid, has been replacing slowly MRI. So there are the classic findings of the thickness of the ventricle, diastolic dysfunction, abnormalities in the valves, pericardial effusion, and abnormal strain. And this is one of the diagnosis tools that we use for the initial diagnosis, but also for the follow-up of these patients. And then, of course, MRI. In many centers, MRI is still the gold standard. There are classic changes on the MRI. The problem with the MRI, you cannot identify the subtype of amyloidosis, so you always need the combination of other markers to determine the diagnosis. But one of the ways to see the progression of the disease and the response of some of the treatments that we are using is to use MRI as well. And I would say that probably the gold standard to diagnose TTR amyloid is the scintigraphy. We call the PYP or pyrosulfate test. This is a test that is very sensitive and specific to determine TTR involvement in the heart. We have a qualitative score that goes 0, 1, 2, and 3. And then a quantitative score that is more than 1.5 is diagnostic and prognostic. So these are the tests that we use all the time to diagnose TTR amyloid. Keeping also in mind that patients with AL amyloid, around 8 to 10% of those patients could have an abnormal PYP nuclear scan. So again, that's the importance of the putting all together with biomarkers and the clinical red flags to the identified patients and pull the label of TTR amyloid. And then finally, we do the genetic testing. So the genetic testing can help you identify patients who have wild-type amyloid versus the hereditary or hATTR amyloid. It's a very simple test. It may take 2 to 4 weeks, saliva, blood test, and in many labs now are done. And here in Ontario, you can order that test through Life Labs or any other providers. So this is the table that we published a few years ago now, how we wrap up things. So once you have the suspicions of cardiac amyloidosis based on the echo or MRI, the ECG, the biomarkers, then the first thing you need to do is to rule out any type of blood dyscrasia. So you do the serum line change, immunofixation, kappa lambda ratio. If that is positive, well, those are the patients who will need to be seen by a hematologist for eventually a bone marrow biopsy. And these patients will require specific treatment that I'm not going to discuss today. And those, when that algorithm is negative, then you have to do the PYP nuclear scan that gives you the confirmation. And then you do the genetic testing to identify hATTR versus wild-type TTR, and you reach the diagnosis. In some situations where you have elevated kappa lambda ratio, but a positive PYP scan, or in cases that all the tests are negative, but you still suspect the presence of amyloid, that's when the role of a heart biopsy is important. So talking about the treatment for amyloid is limited. So what Harriette and Shelley discussed today, unfortunately, we cannot apply all these drugs in patients with amyloid because it has a very particular phenotype, and the response to treatment usually is not as we would like to see. Sometimes we just are limited to reduce congestion. and sometimes it's the only thing we can do for these patients. But keep in mind that these patients depend a lot on the preload. So if we dry them out, they will pass out. If they are wet, they will not be able to breathe. So finding that fine line is essential in these patients. All the drugs that we discussed earlier, unfortunately, they have side effects or are contraindicated in the context of amyloidosis. Some of them, in fact, can be toxic, particularly digoxin or calcium channel blockers can increase the toxicity, and these patients may have side effects related to the binding of these drugs to the amyloid fibers. So usually are not well tolerated, especially in more advanced cases with autonomic dysfunction. They are very, very poorly tolerated. And as arrhythmias are very common to see, unfortunately, the conventional therapies are not very well tolerated. Sometimes we are limited to use amiodarone, catheter ablation in very refractory cases, but the successful rate is very low. So keep that in mind. And then, of course, when they have hypotension, sometimes we are limited to use alpha-1 blockers like midodrine in these patients. So as you can see, the conventional heart failure therapies are very limited in these patients. I would like to spend a few minutes now to talk about specific therapies for amyloidosis. These are not drugs that are only prescribed by cardiologists or cardio-oncologists. I think in the last few years we learned that these drugs are very easy to use, and you will be prescribing, I'm sure, in the near future. So that's what I wanted to put some emphasis on these therapies. So as you can see here, the TTR, you have the production of the protein in the liver, so it's the messenger RNA. Then you have this protein, which is the 4 monomers linked or bound here in the middle, and then they start the misfolding process. So when this happens, it's too late. So there are 2 groups of drugs that are currently available and approved, of course, in Canada for the treatment of patients with TTR amyloid. So one group is we call the silencers here, and the other one is the stabilizers. So the stabilizers basically, they stabilize this molecule to prevent the misfolding and to prevent all this to happen. And then you have the silencers, which what they do is they block the production of the messenger RNA, so the production of the protein in the liver is blocked, so called silencers. And these are some examples that I'm going to discuss a little more in detail. So you probably hear about the ATTRACT trial. This is the first trial published a few years ago now that showed that in patients with TTR amyloid, either hereditary or wild type, if you treat them with this stabilizer called tafamidis, you can see a significant reduction in the main outcome of this trial, which is all-cause mortality. So it's the first study showing that a drug can change the way we treat patients with amyloidosis, a 30% reduction, relative reduction in the risk of death. And you can see here that the curves start diverting in around 18 months and turn significant after. And this is something that we see usually in any type of clinical trial with chronic heart failure. And not only you can see improvement in survival, but also, you can see that these patients are able to walk more and they feel better. And this is usually what patients tell you after a few months of being on this drug, tafamidis, that's what they notice. We recently submitted a paper of real-life patients. So these are the patients who are in the last few years on tafamidis, and we observed the same results that we're seeing in these patients. Now, not everybody is a good candidate for tafamidis. And this is important, the selection of the patients. We know that tafamidis, when it's used in patients with much more advanced heart failure symptoms, usually these patients don't have the survival benefit. They don't see the reduction in hospitalizations. So the key message is trying to identify these patients earlier in the course of the disease when they're class 1 or 2, when the BNP is less than, NT-proBNP is less than 2,000, when the creatinine or creatinine clearance is more than 40 or 50. So these are the patients who have the most benefit, and this is something that we are seeing in most of the trials and studies published in the last year. If we move briefly to the silencers, again, silencers interfere with the messenger RNA. There are different ways to block this, and there are different drugs to do that. This is the first generation of drugs inotersen. It's a subcutaneous drug, recently discontinued from the market, and patisiran, which is an intravenous drug, which is still available. So these drugs have shown in patients with hereditary TTR amyloid with ambulatory polyneuropathy a significant improvement. And there was a signal in these trials that it was also beneficial with patients with cardiac involvement. At this point, these drugs are approved here in Canada for patients with polyneuropathy, and eventually in those patients with hereditary TTR with a mixed phenotype, so mostly neuropathy and cardiac involvement. But there is no approval at this point of these drugs for pure patients with cardiac phenotype, but it's going to happen. So this is an important trial that I was very fortunate to be part of. This is the Helios B trial that was recently published, and I wanted to share some of the data from this important trial. So this is a second generation of silencers. This is vutrisiran. And this drug is different from patisiran or inotersen because this is a more selective drug that goes direct into specific receptors in the hepatocyte. By doing that, this drug is much more potent, less side effect profile, and instead of using it weekly or every 3 to 4 weeks, this drug is used subcutaneously only every 3 months. Thank you. So the trial involved patients with HATTR and wild-type TTR amyloidosis. They were randomized to receive vutrisiran subcutaneously or placebo. This is the primary endpoint on composite outcome of all-cause mortality and recurrent cardiovascular events. And then there were 4 secondary endpoints like 6-minute walk, Kansas City questionnaire, all-cause mortality at 42 months, and New York Heart Functional Class. And for the purpose of the analysis of this trial, they analyzed the overall population and another group called the monotherapy group, which is the patients who receive only vutrisiran without tafamidis. So that basically represents 10 pre-specified endpoints in total. So this is an important trial because it's a little bit different from the ATTRACT trial. So these are patients who are less symptomatic and treated with more contemporary drugs. So you can see here, 40% of these patients were on tafamidis at baseline, and an additional 20% patients received tafamidis during the course of the trial. 3% of the patients were on an SGLT2 inhibitor, and around 30% of those patients were on an SGLT2 inhibitor during the course of the trial, and there was also more use of diuretics. So that tells you it's a different population, less symptomatic, more of them class 1 and 2, representing more the real world data. And this trial showed that patients who receive vutrisiran has a 28% reduction in the primary outcome compared to placebo. The curve seems to be diverting a little bit earlier than ATTRACT. And in terms of the all-cause mortality, which is secondary endpoint at 42 months, also there was a significant reduction at 36%. This is in the overall population. All the pre-specified subgroups were positive, were in favor of using vutrisiran, but it seems that those patients who were younger and patients with less BNP, so the earlier disease, they had more benefit. And there were no differences really in those patients who received tafamidis versus those who did not receive. Now, an important question, and I don't think this trial was designed to answer the question, is what happens in those patients who receive dual therapy, vutrisiran and tafamidis. And even though it was not significant in terms of the primary and secondary outcome, we can see a trend of benefit in those patients who receive dual therapy. Again, this trial was not designed to address that question, and probably we need a longer follow-up to see the results of this. But it's an interesting finding, and we may learn more about this in the next few years. When we see the secondary outcomes that I described earlier, everything is in favor of vutrisiran. Patients feel better, they're able to walk more, NYHA functional class improve. And finally, biomarkers. You can see there are more stable biomarkers in those who receive vutrisiran versus placebo. So just to wrap up, I think I have a couple of minutes. what is the future of the treatment of amyloidosis. So currently we are enrolling patients in this trial called the Momentum trial, which is the use of gene editing to modify or change the TTR gene and able to block the production of the protein, but at the gene level. So this is fascinating technology using CRISPR-Cas9. There is data already published with the benefits and the safety of this technology, and we're currently enrolling patients in this trial. And then the second trial is the use of humanized monoclonal antibodies to bind to the amyloid that is deposited in the heart and remove that. So this is a third group of drugs called the degraders. So remove the amyloid that is already deposited. This is one of the drugs that we're studying in the Deplete TTR trial. And hopefully we can see this another option for patients with amyloidosis. And we can see recently published data that some of the MRI data shows that patients who receive these antibodies have a significant improvement in some of the parameters here. So just to summarize, what is the current treatment options for these patients? Here we are now exploring the gene editing, which I think is going to change the way we treat these patients. We could eventually offer this therapy for patients early in the course of the disease and prevent any other problems. Then we have the silencers. We talk about vutrisiran. There is another drug called eplotensor that is a second generation that has been currently studied in another trial. We may have results in the next year or so. So we may have two silencers to treat patients with TTR amyloid. And then we talk about the stabilizers, tafamidis being the one that is approved here in Canada. There is another called acoramidis that seems promising, and this could be another drug available for us in the future. And then you have the degraders that are, at this point, nothing has been approved, and hopefully the monoclonal antibodies could answer some of these questions. So in conclusion, you can see that there is significant advancements in the management of amyloidosis. There are a lot of developments in the diagnostic and also in treatment for these patients. There is a lot of research that is missing still, particularly what is the optimal monitoring strategy for these patients, individualized timing and selection of the different type of drugs that we have currently and we're going to have in the next few years. And also, I think it's important that we don't have at this point any treatments for patients who are asymptomatic, and we don't know really how to identify these patients properly. So there is a lot of things that we're learning, and hopefully in the next few years we'll have more information. Thank you for your attention.
Yeah, I think we're going to step up to the front so that we can just do our discussion and Q&A. Thank you for submitting your questions. If I could invite my esteemed speakers to join me. This is very cozy. I'll sit at the end.
I was trying to stay seated right there.
Right, you did your best. I know, sorry about that. Okay, well, thanks everyone for submitting your questions, and thanks for 3 great talks. So I'm going to start with some that have been submitted through Slido, and this is really down to, really directed to Shelley with the decongestion. Despite the ADVAR data showing the benefits of acetazolamide, I'm not seeing anyone use these strategies or therapies, whereas there are lots of implementation of SGLT2 inhibitors, thiazide, despite less data. Can we give IV acetazolamide on the wards, or do they need to be in a critical care setting, and are you using it?
You're correct. I don't think there's been a lot of uptake of the ADVAR protocol in Canada. It is available. It's just not on most of our inpatient order sets, and it definitely is available. So it's about modifying your order sets to get access to it. But I think most people default to using oral acetazolamide, which of course was not part of the study protocol. So I've seen some increase in oral acetazolamide, which is available on most diuretic order sets. But IV, I think we need to make the effort to make sure it's on our formulary and on our cardiology order sets. I think it's used for ophthalmologic issues and things like that. So it's definitely available. And then in terms of urinary sodium, also not on most clinical care pathways for the management of heart failure thus far.
Yeah, I know that nephrologists are often fans, so I often have patients who show up and in nephrology have initiated the therapy and their heart failure benefits as a secondary thing, but I don't use it myself very much, you know, so.
Can I say something? Patients with one of the exclusion criteria were patients on an SGLT2 inhibitors, because this drug can also has some SGLT2 inhibitor properties. So really it's very difficult to today to make strong conclusions about the use of this drug because there are no SGLT2 inhibitor use in this drug. So I've used it 2 or 3 times oral with very limited results. So I think we need to put things into context. Maybe it's not one of the choices in the future.
The other consideration is that patients who entered the trial had a limit in the dose of furosemide that was allowed. And patients who we typically think of for add-on therapy well exceed that dose of furosemide. So we typically have patients over 100 milligrams of furosemide, for example, before we think of add-on therapies. Another thought is that many of these sequential nephron blockade agents can facilitate more urine output, but they are also associated with metabolic abnormalities, electrolyte abnormalities, and they don't change clinical endpoints beyond the first several days. So if you have other ways to get a bang for your buck that improves symptoms but also prolongs life, reduces heart failure events, those might be better options than some of the sequential nephron blockade tools in our toolkit.
Thanks. So I have another couple of questions here that we can combine. Is there a role and are there data for in-hospital nitrates, either IV or oral, to augment decongestion with diuretics? And also, do we have data on efficacy of biomarker-driven strategies to improve decongestion in or out of hospital? So I guess Shelley covered a lot of decongestion, but we'll deal with that.
I don't know about the IV nitrates. I don't know of any recent contemporary data. There's probably some sort of hemodynamic data out there, but perhaps Diego or Harriette know. And in terms of natriuretic peptide testing, there's enough evidence, at least, that CCS has made a suggestion or a recommendation. There's a table from the 2017 guidelines that they actually suggest that a reduction in NT-proBNP by about a third suggests that it's safer and more reasonable to discharge the patient at that point in time. And I think, you know, we definitely saw in STRONG-HF this robust reduction in NT-proBNP with initiation of GDMT and an improvement in clinical outcomes as well. So, I mean, I think there's enough to support intermittent monitoring. I think frequent monitoring, I don't tend to monitor daily NT-proBNPs. I think that's unnecessary. I tend to do it when they are admitted and then a pre-discharge as well to reassure myself. And as an outpatient, we don't do routine NT-proBNP monitoring unless there's been a change in symptom burden.
Great. I'm going to use my moderator privilege and ask one of my own questions, which I was fascinated by the slide when you talked about that you get a reduction of death if you make sure people are properly decongested before they're discharged. Like if they don't have orthopnea and ankle swelling before they go home, then they're much less likely to die. Whereas we all understand that diuretics don't improve mortality.
Yeah, so that's just really an association, right?
So it's an association. So you think, well, you know, what's the mechanism? Is it just these are actually sicker patients and they're more resistant and they're more likely to die because of that? Or is, is this a pump failure? Is
Yeah,
it just
and I don't think that was adjusted for GDMT use either. So there's a lot of confounders in that as well. Certainly not an adequately powered evaluation, but intuitively, if there is a reduction in heart failure hospitalization, there should be an improvement in outcome. We know that with each serial heart failure hospitalization, there's a worsening of prognosis. So, I think, this is sort of where we implore people to look beyond the admission or the presentation right in front of you. I had a gentleman I saw in heart function clinic just yesterday, frankly, who, for the first time, who'd had 6 heart failure hospitalizations since August, right? And so, there's no discharge weight on this man. Within a week of discharge from a non-cardiology ward, he is gasping for air in my clinic because of issues of not being able to fill his prescriptions and things like that. So we need to do better. We need to look back 6 months to a year on your patient's record to see if they've been hospitalized for heart failure. It really changes their prognosis and really should implore you with the urgency to treat and prescribe GDMT in this setting.
I'm going to rock the boat a little bit and say that we really don't know that loop diuretics don't improve mortality. There's been 3 tiny RCTs. I think the combined sample size is 200 and something patients. You really can't randomize congested patients to a diuretic versus no diuretic. There were clinical improvements in patients on loop diuretics in those small trials. I would say that the most important factor that limits quality of life and functional capacity in our patients is congestion. And so we can't leave patients untreated. So I would endorse decongestion and the use of loop diuretics and not underestimate their effect on patients' symptoms. And just to clarify, we haven't had good quality trial data because it's hard to run those trials.
Yeah, and everything that goes in the same direction as mortality benefit, like hospitalizations, quality of life, BNP, all of the things head towards mortality benefit in larger studies. So you'd assume that it does have a beneficial effect. So I've got a couple for Diego. First of all, in patients with cardiac amyloidosis and HFrEF, for the standard GDMT therapies, should we continue to avoid beta blocker, ACE inhibitor, ARB in these patients? Just on principle because they have amyloid?
Yeah, that's a good question. So the general rule, and if you see our guidelines, and it was not a consensus, but some centers, they stop beta blockers right away as soon as the diagnosis is made. In other centers, like ours, we keep the beta blockers if there's a clear indication and if there are no side effects. I would say that the rule is that we try to put them on heart failure therapies if they are able to tolerate. The data there is no strong data, as you all know, in the use of all the GDMT in these patients, but we try to use them. In patients who are more advanced symptoms, we all know they don't tolerate that, and we are limited to a mineralocorticoid receptor antagonist, maybe finerenone, and an SGLT2 inhibitor. SGLT2 inhibitor, I believe, is probably the drug of choice for these patients. There is more and more data of using DAPA or EMPA in these patients with significant benefits. There's no randomized trials yet. There are 2 or 3 publications, but I will say consider an MRA and an SGLT2 inhibitor as first line, and then you can eventually try other drugs.
Sticking with you, Diego, got another couple of questions coming in. Somebody wanted to ask about the PYP scans, which, as you know, we used to be stuck with having to do an endomyocardial biopsy with the inherent risk, and of course we hardly do them now for diagnosis, or we never do them now for diagnosis of amyloid because of PYP scans. And they're asking, really, have we always had this scan available and we've just only started using it, or has it been a more recent development?
So the PYP has been around for 30 years. It's not a new technology. We've been doing that for MI diagnosis 20, 30 years ago. But now we know that it's very sensitive to detect the deposit of the TTR fiber, so it's gold standard at this point. Reality that in many labs are doing PYPs now. 5 years ago was, I think, Toronto General only, but now, at least in Ontario, we have 10 nuclear labs that they're doing this test. It's a learning curve, but reality, there are very, very good tests in many centers. As you can see, you have a qualitative and a quantitative score. Both had to be reported, had to be done with SPECT, so it increases the sensitivity of the test, and that has replaced the biopsy. We barely do biopsies at this point for these patients. Yeah.
So I'm going to do a combined question. I'll direct it to Harriette first, and then the panel can weigh in. So for all of these conditions, both amyloid, HFpEF, HFrEF, should we have a formulaic approach with EMR prompts and then compare performances? Is that something that we should be pushing for? And also, as another question, somebody asked about our experience with the use of novel agents and strategies in ambulatory heart failure, such as vericiguat, peer pressure monitoring devices. Do we use them? How effective do we find them? So Harriette, I'll put you on the spot first.
Sure. I think that a major limitation and uptake of our therapies is the organ-based approach that we adopt. And we often forget that the patient living with heart failure also has diabetes, hypertension, atrial fibrillation, kidney disease. And there's really an unmet need of integrating guidelines across these organ-based evidence generation pathways and implementation pathways, and bringing it all to life for the person in front of us in a way that accounts for drug-drug interactions, burden on the patient, and the very real issue of the kind of care they need, the impact on their lives, on their families, on the labs we order. And yes, EHR prompts can be useful, but in reality, even the centers that randomized patients to these kind of EHR prompts, first of all, the trials were single center trials, as in they were within one healthcare system, because many systems differ in the kind of EHRs that they have. They also slow down the actual EHR, and they're very expensive. So many hospitals do not want to support them. Another factor is that they tend to be organ specific, which is why I think we need more integration. And a way to sort of synergize all of these guideline recommendations so clinicians know what to do and patients know what to take. And we prioritize those drugs that both improve lifespan, heart failure events, and how patients feel above those that really may improve a surrogate outcome or two. So we are testing an algorithm-driven approach that's phenotypic in nature, that accounts for the comorbidities, that prioritizes drugs based on what they add in terms of value to the patient, and then deploys it in a manner that's agnostic of technology. So we have in low-income environments, low economy countries, paper-based systems, and then we have apps for higher economy settings. And I think we need to tailor our interventions to what's available, accessible, affordable within countries, and the existing systems of care. So I would say that EHR prompts may be effective in a trial and in a given hospital if there's funding for it, but it's not widely applicable. And so we need to think about interventions that are scalable across resource settings to really change the way care is delivered.
You want to say something? Not much to add. I will say two things. You mentioned about vericiguat. I think this is a good option for patients with reduced EF, class 2, 3 symptoms. It's another tool that we have available for patients with heart failure. Of course, in the amyloid context, there's no data. I want to say also, is important role of artificial intelligence in all the things we talked today. I think moving forward, this is how we're going to identify patients and treat patients. I think there's a lot of work in that. In the context of amyloid, we're working on a few projects trying to identify based on different algorithms using clinical data, imaging, biomarkers, identify these patients earlier, because at least in amyloidosis, we know that we start earlier, we can save lives. So a lot of things that happening in the world of heart failure to treat and identify patients.
Just one other consideration here as well is, groups like Ted Rogers, I hope really, advocate for access to these medications for patients across Canada. There are really regional disparities in terms of who qualifies for what drugs, cost as well, different insurance coverage across provinces. And so, I think a pan-Canadian approach will really help improve access to heart failure therapies.
Well, thanks everyone. I think we've got a packed room and the questions keep coming in, so we could sit here for the rest of the day, but I'm conscious that we need a health break and we've got other things to go to. So we're going to have our health break now for 20 minutes, and then the next session at 11:20, which is in the big room, is the joint plenary sessions, which are, of course, acute care issues, but not specific to, a CVICU or a CICU attending. They're for all people practicing in acute cardiology. So that's our joint session until 1 p.m. Thanks very much.